Welcome back to The Explainer, everyone. Today, we're cracking open the Rulebook for Evaluation and Management, or E&M codes, to really understand how to properly log encounters across totally different medical settings. Look, if you want to ensure proper reimbursement and, avoid that dreaded payer audit, you absolutely have to master this area of medical billing. E&M codes are the most frequently billed codes in the entire industry, covering almost every non-invasive interaction a doctor has with a patient. So let's get our facts straight. Here is a quick look at what we are covering today. The core elements of E&M: office visit dynamics, hospital encounters and status, navigating consultation visits, and finally, time-based consultations. Let's dive in.
Section 1. The core elements of E&M, which is really the foundation of every single visit. Okay, so no matter where a patient is actually seen, whether it's a bustling clinic, the ER, a nursing home, or literally their own living room, every E&M code is built on the exact same fundamental triad of provider actions. Step 1 is gathering the patient's background history. And this isn't just asking, hey, why are you here? It involves documenting the primary complaint, personal history, family history, and social habits. The more detailed this is, the easier it is to justify a higher level of payment later. Step 2 is conducting the physical exam. Now, this might just focus on a specific body part, or it could span multiple organ systems. And finally, Step 3, which is absolutely crucial, is establishing the medical decision-making, or MDM. This determines the complexity of the treatment required. The service level billed is heavily determined by how much actual medical treatment the condition requires. I mean, if a patient just has a mild cold, you can't legitimately charge a high-level visit even if the doctor did a full-body exam. The decision-making just has to match the reality of the illness.
All right, Section 2, office visit dynamics and differentiating the routine.
Let's move over to the doctor's office. Here, your coding choices heavily depend on the patient's prior history with the practice and, well, who is actually administering the care. A really critical rule to remember here is that new patients require distinct, higher-paying CPT codes. Why? Because they naturally take up way more of the physician's time. But what exactly defines new? Well, a patient is officially considered new if it's their very first visit or, and this is key, they haven't been seen by any practitioner at that specific practice in over 3 years. If they were seen, say, 2 years ago, actually, scratch that, even 2.5 years ago, they are an established patient, and you have to code them as a routine returning patient. Misidentifying this is a really quick way to either leave rightful revenue on the table or illegally overbill the payer.
Another major dynamic in the office is figuring out who is actually providing the service. When a non-physician practitioner handles an office visit, like a nurse practitioner or a physician assistant, you've really got to navigate state laws and highly specific insurance contracts. While the procedure codes they use are identical to a doctor's, the payer often reimburses them at a totally different rate. Typically, a licensed physician must be physically present in the office suite. More importantly, insurance companies often require special modifiers on your claim to clearly flag that the attending physician was not the one seen. You absolutely have to know the specific quirks of every single payer contract your office deals with.
To efficiently track all these routine encounters, doctors frequently use something called a superbill. Basically, this is a paper or digital checklist that lets them rapidly tick off the diagnoses and procedures performed during the visit. Now, as the coder, your job is to review this superbill incredibly carefully. You have to cross-reference it with the actual medical record to make absolutely sure that every single box the doctor checked is fully supported by the documented medical history and that the diagnosis legally justifies the treatment provided.
Section 3. Hospital encounters and status and dealing with escalating severity.
Transitioning from the office to the hospital, the coding logic shifts dramatically to an escalation model. It's based strictly on the severity of the patient's illness and the medical risk involved. Simply put, the sicker the patient, the higher the risk, and subsequently, the higher the reimbursement. Hospital codes operate on 3 distinct levels of escalation. Level 1 is used when the patient is recovering right as expected. The doctor reviews the chart, notes the progress, and the decision-making is moderate. Level 2 triggers when the patient just isn't getting better as expected. This means the doctor has to intervene further, maybe issue some new instructions to the nurses, or order new lab tests. Finally, Level 3 is reserved for patients who are rapidly deteriorating or failing to respond to therapy at all. This level demands significantly more of the physician's time, involves highly complex medical decision-making, and carries a very high risk of severe complications or even death.
Now, looking at this, it brilliantly illustrates a common compliance trap. As you review hospital documentation, keep in mind that hospital coding is entirely dynamic. So if a patient's extremely poor health actually begins to improve, you are legally required to downgrade your coding from a level 3 back to those lower level codes. You definitely cannot just lock in a level 3 code for their entire stay just because they were critically ill on day 1. Your coding has to actively track their recovery trajectory.
So, a really crucial point here is establishing the patient's actual status. And guys, here is a major trap you want to avoid. Simply spending the night in a hospital bed does not automatically make someone an inpatient. Inpatient status explicitly requires a formal written admission order from a physician. If a patient rolls in through the ER, gets some tests, and stays overnight for observation, without that formal admission order, they remain an outpatient. It's that simple. Misrepresenting a patient's status can literally lead to accusations of fraud. So always check for that physician's directive.
Moving right along to Section 4, navigating consultation visits, which come with strict criteria for high pay.
Now, we have to look at consultation visits. These are highly scrutinized by auditors because, frankly, they usually command the highest reimbursement rates in E&M coding. But a consultation isn't just a specialized assessment. It is a very specific administrative workflow. To legally bill it, you have to meet 3 strict criteria. First, there must be a written request from another healthcare professional, like another doctor, a social worker, or an insurance company. Second, there must be clear documentation of medical necessity right there in the file, explicitly stating why the consult was needed. Third, and this is where so many claims fail, a formal written report of the consulting physician's findings must be sent back to the requesting provider.
As a coder, you have to verify exactly how the patient ended up in that specific office. If any of this required documentation is missing, let's say the doctors just forgot to send the written report back to the referring clinic, the claim is going to be straight up denied by the payer. Or it'll be downcoded to a standard new patient visit, which pays way less. Always confirm the paper trail.
Finally, Section 5, time-based consultations and the famous 50% rule.
Let's explore a really unique scenario where these high-level consultations are billed purely based on the clock, rather than the clinical complexity of medical decision-making. When you are billing a consultation based on time, you absolutely must adhere to the 50% rule. This means that at least half of the total recorded face-to-face time must be spent counseling the patient on their test findings and their various treatment options. So, if a physician spends an hour with a patient, at least 30 solid minutes of that must be dedicated strictly to counseling and discussing options for this time-based coding to be valid.
For this time-based code to be compliant, the provider's documentation can't just lazily list the total minutes. It must explicitly state the total time of the visit, it has to break out the specific amount of time spent on counseling, and it needs to provide a clear, written synopsis of what was actually discussed during that meeting. Without that written synopsis and the exact time breakdown, your time-based claim will not survive an audit.
Well, that wraps up our rulebook overview for today's E&M categories. Before you log your very next encounter, just ask yourself, could a single missing signature or a misplaced timestamp cost your practice its rightful revenue? Mastering these codes isn't just about compliance, it's about protecting the true value of the care being provided. Please like, share, and subscribe to Decode Healthcare with Harshal.